This is not my first rodeo in New Jersey. I was involved in the Comprehensive Primary Care Initiative. I was thrilled when New Jersey took it on. And frankly, it's moving for me to be able to come to a place some years after and see how many people are engaged in the work and how much difference that we collectively are making. So that's great to see. And but as Linda said, what I'm going to be focusing on today is the Choosing Wisely campaign. I'm glad to hear many of you know about it. And what I'll try to do is provide a combination of some background about how it came to be, because it has a number of moving parts that draw from engineering, from complexity theory, from the way we think about making change happen, and then also to give you some examples to show you that things really are happening that are pretty impressive. And as you heard earlier, there's a lot of waste going on in healthcare, and that 30% number comes from the Institute of Medicine. What causes it? Well, some of it's patient-driven. I already figured it out on the internet. I just need a second opinion. But a lot of it's doctor-driven. We're kind of uncertain. Well, it looks like an arrow through the head, but we want to do a bunch of tests to be sure, maybe a CAT scan. So the basis for the Choosing Wisely campaign really was a charter on medical professionalism. And again, as you've heard, a big issue is cost. But if you sit down with clinicians, frontline clinicians, and you say, hey, we just signed this new contract with global payment and cost accountability, and if you guys don't start ordering fewer MRIs, we're going to lose our shirts, so would you please change your practice patterns? I think any of you who have worked with frontline clinicians know that nobody went to medical school to fix the national debt or the GDP or control the cost of the Medicare program. It's not why people become clinicians. But they do have a professional animation, something that animates the way they think about their work. And the ABIM Foundation in 2001, 2002, in partnership with the American College of Physicians Foundation and the European Federation of Internal Medicine, created this Code of Ethics for the 21st Century. And I got to say, I was underwhelmed in 2001, 2002 when I heard about this. There's lots of codes of ethics that are on a bookshelf and nobody ever looks at them. But one of the things that it called for was that just distribution of resources was to some extent an individual physician responsibility. And when I trained more years ago than I care to remember, any time a physician was thinking about anything other than the patient right in front of them, that was considered a priori unethical, immoral, unprofessional. You were only supposed to be thinking about the patient in front of you. That's all ever. And any expectation that you did anything else would be considered deeply unprofessional. But as Victor Fuchs once put it, a healthcare economist who's 95 and still publishing, he said, the American healthcare system's like a luxury ocean liner. There's a bunch of people on board who can have anything they want. They can eat, they can drink, they can go to the casino. But at the time he said this, there were close to 60 million uninsured people in the United States. And he said, on that luxury ocean liner, we threw 60 million people overboard and nobody even heard the splash. And the idea that somehow the decisions that doctors are making for the patients in front of them have consequences for the patients not in front of them, as well as the rest of society, is something that became an animating professional value that led to the creation of Choosing Wisely, calling on clinicians thinking about their professional obligation to use resources responsibly. And the charter articulated it as a principle, but Choosing Wisely turned it into a practice. Howard Brody suggested in the New England Journal that maybe professional societies could develop lists of 5 things. And it's kind of interesting, it really turned the guideline development process on its head. Bring a bunch of experts together. What we used to do is we'd say, well, what's the right way to treat hepatitis B? And you'd bring a bunch of experts together and they'd review all the literature and they'd come out with a monograph on all the things you should do. This was different. This was, well, what are the things maybe you shouldn't do? What are the things maybe that are being done too much? The program launched in April of 2012. As Linda mentioned, it was to focus on conversations about overuse, to focus on high-value care, and to make smart, effective choices. And some of the ways that the campaign's been criticized is, hey, there's still waste in America. Yes, there are, and you can buy chainsaws in hardware stores, but there are still trees in America. It's a tool that can be used, and when it's used appropriately, it can be very helpful in reducing waste, and I hope to give you some examples of that. This is kind of what the product looks like. The original partnership was with Consumer Reports, and they helped us develop patient accessible, friendly kinds of materials. And the campaign is remarkable. We're a pretty small foundation, $70 million, give or take. In healthcare, that's nothing. And yet, we've been able to, many of you are aware of it. Awareness is high, as I'll talk about. Over 80 specialty society partners, bunches of recommendations, 2 rounds of investment from the Robert Wood Johnson Foundation, which I'll be talking about, a bunch of employer consumer groups, and tons of journal article mentions. And we're now international and in 19 countries. This after our board said to Daniel Wolfson, our EVP, don't take this campaign internationally where we don't have the resources to do it. So we didn't do this. It kind of did itself, and now there's Choosing Wisely all over the world. So what are some of the lessons that we learned? And I'm going to elaborate on each one of these as I go. First, the power of messaging and framing. It matters how you talk about it. If you're talking about we need to save money, you're going to lose clinicians. There are other ways to talk about it. Simple rules. How do you do something that engages so many people? The simple rules are a core part of that. I'll be talking about those. Engagement and partnership. Nobody does stuff alone. The group of people in this room, it's a pretty interesting combination, right? A lot of tech people, a lot of clinical people, a lot of entrepreneurial people. Figuring out how to build alliances and partnerships was critical to the success of the campaign. A bottom-up approach with support so that it's not top-down, it's not us telling people what to do or anybody telling what to do, it's giving people a framework, a flexible, adaptable framework that they can use. And definitely getting back to the point of engineering redesign, need for system and performance improvement approaches, that it's a tool, but it is most effective when it's integrated into workflows in a systematic way. So the power of messaging, as I've said, talking about cost is kind of a loser, but avoiding harm, what's the benefit, that's something that clinicians and patients care about. And patients are pretty increasingly suspicious these days. They know that the healthcare world is changing. They know that contracts are changing in accountable ways. And when I was in practice, I remember a patient came in who did not need a colonoscopy and asked for a colonoscopy. And I said, that's really a bad idea for you. And he said, are you telling me that because the insurance company is going to pay you less if you do it? Well, at the point at which we've got patient-level awareness like that, and they're worried that when we make recommendations not to do stuff, that maybe we have economic motives, the ability to have that conversation on straight-up clinical motives, what will this do for you, what are the risks, what are the harms, is something really, really, really important to get into. I mentioned the idea of simple rules. There's a whole theory of complexity, and if you avoid central planning and instead try to engage participants, you may get a lot more uptake. You may get a lot more participation, and this is probably a generalizable rule. Everything I'm talking to you about today, all 80 societies, all of the recommendations, all of the partnerships, these were the 4 rules, only 4 rules for Choosing Wisely that the foundation put forward and invited people to basically play on this space. There's really a 5th rule, which is the product you're trying to produce is a list of 5 things, as I mentioned at the beginning. But the product you produce as a specialty society needed to be within your specialty. So if you were an orthopedist, you didn't get to talk about what the radiologists were supposed to do. You needed to talk about stuff that was in your specialty. It needed to be of consequence, of impact, either because it was frequently used or because it was costly. You needed to be evidence-based, that the process you used, you needed to be able to cite references that would say, this is why we're recommending this. It needed to be transparent. And basically, any specialty society that was willing to come forward and do those things could join the Choosing Wisely campaign, and as I say, 80 of them did. I talk about engagement and partnership. these are not recommendations of the ABIM Foundation. These are recommendations from professional societies. We have had conversations with payers, but we haven't said to payers, we want you to hard code choosing wisely as a rule. Lots of payers have asked us about that, but clinicians hate prior authorization. This is supporting conversations, not supporting payment policy design. Lots of partnerships with the delivery system, which I'll be talking about, some partnerships with government and consumer groups, employers. When this hit the ground, it hit the ground as this is something that the American College of Cardiology, together with Consumer Reports, under the aegis of the ABIM Foundation, and often distributed by other trusted brands, AARP or healthcare delivery systems, so that it came with a kind of trust pedigree, which came from engagement and partnership. And these are some of the people who got on board. And you can see it's a lot of different folks. These are folks on the business side and patient advocacy side. These are folks more on the clinician and tech support side and hospital networks and stuff. So what are the drivers of overuse? Well, the intrinsic ones are probably the most powerful. The belief that more care is better. Can you supersize that? Right? I mean, that's kind of core to what we believe. If a little is good, more is better. And in healthcare, not so much. There's also not that much awareness of harm from overuse. People are much more worried about, I'm going to get into trouble for not doing stuff. But in fact, we can get into a lot of trouble doing stuff too, and we do. And another major driver is discomfort with uncertainty. You know, you're a clinician, a patient comes in with a problem, you're pretty sure, but not sure that it's an arrow through the head. Maybe you are going to start ordering testing to try to manage that uncertainty. It's one of the things clinicians do. And then, of course, there's a bunch of extrinsic drivers. I mean, in the fee-for-service system that we have, the financial driver is a big driver. Not only do you derive some sense of reassurance from doing more testing, you drive increased revenue. This culture that, you know, we want to avoid mortality, a lot of this stuff gets done toward the end of life without necessarily much benefit. There's a whole industry of people pushing out, let me tell you about the new development, whether it's pharma, whether it's academic health centers, you know, we've got new treatments we want you to know about. Advocacy groups are out there too, trying to say, you know, you should be doing more. And certainly the medicalization of non-disease. You know, your toenail looks funny, I've got an $800 treatment for that. There's a lot of stuff out there that now is sort of, so these are all big drivers of why, and it isn't any one thing. And choosing wisely is meant to land at the clinician-patient interface where, in effect, two people are processing a bunch of stuff coming out them and trying to make decisions. That's where it lands. So I'm going to start getting into some examples. This is a Connecticut example, which was a statewide collaborative, and what they did was they used the cards that are on the tables, and the cards are in English and in Spanish, and to enhance physician-patient communication. And frankly, when I was getting ready for this talk, I looked at these cards. I thought, wow, this is like actually a pretty cool product. And no kidding, I mailed them to each of my kids and I said, look, I'm a doctor, you know, I know you come to me for medical advice, but if I were going to give you sort of overarching advice for how you can manage any interaction in the healthcare system, I'm not sure I can improve on what's on these cards. And I honestly felt that way. It was like, wow, these are even more user-friendly and applicable and generalizable than I thought. So Connecticut used these, and you know, it was statewide, and they were able to demonstrate engagement and use over a period of time. But the other kinds of examples I'm going to present have data on impact on cost and change in practice. Maine Quality Counts is a statewide initiative that was one of the ones supported by the RWJ grant, and their interventions included a variety of things, as you see, but one of which was workflow changes. You'll see, by the way, that the results they got included significant reductions in the use of benzodiazepines. These were American Geriatric Society guidelines. Those drugs are dangerous in older people. But they also reduced opioid overuse, which in Maine was a pretty big deal. And they came with a workflow change, a workflow redesign process. And as Don Sebastian told us, engineering approaches matter. In healthcare, there are workflows. We don't reliably think of them as workflows. We don't reliably write them down and diagram them the way engineers do. But when you think about making change, thinking about a clinical workflow and your opportunity to locate a process in it matters. So that was an example from Maine Quality Counts. The American College of Radiology, this is another way in. They've got this thing called RScan. A number of the recommendations deal with imaging, and imaging is a major area of inappropriate use. As I point out repeatedly to people, nobody wants an MRI. What they want is to be able to play with their grandchildren or go hiking or ride a bicycle. They don't actually want an MRI. But we have this built-in sense that somehow if we know what it looks like inside, we know something useful. But in fact, imaging is one of the major dangerous overuses, not just because of the radiation exposure of things like CAT scans, which turns out to be pretty substantial, but because, and every clinician knows this, you do the CAT scan, you see something, it's probably nothing, but it might be something, and now you're doing more testing that's actually more dangerous. So this is a very user-friendly way to get into some of the recommendations from the American College of Radiology. And the other group that came out with very diverse recommendations and a friendly way in was the American Society of Clinical Pathology. Laboratory testing is a major source of overuse, and some of the examples I'm going to present to you are hospitals, which are of course paid in a global reimbursement way, and so they're not generating revenue every time they do a test, and you can quantify in avoided tests how much money that saves, and some of the examples I'm going to present do this. But this is another friendly approach toolkit from ASCP. I mentioned that RWJ made 2 rounds of investments. In the second round of investment, they asked us to do a bunch of regional approaches, and they wanted, in the way that RWJ does, they wanted good data on impact, and so they wanted each health system to pick a series of outcomes that they were going to focus on, and then they wanted one or two that went all the way across that everybody did together. And reducing prescription of unnecessary antibiotics was one of the things that went across all the different systems. 12 of 14 systems were able successfully to reduce antibiotic prescribing, and 8 of them met the goal reduction of 20%. 20% reduction in unnecessary antibiotics. And again, in a world where we're seeing lots of antibiotic-related complications, whether it's C. diff colitis or allergy, avoiding unnecessary prescribing is critical. And again, it's a conversation. The patients come in and they say, I know I need an antibiotic, and the ability to say, look, we've got multiple recommendations that this is more likely to hurt you than to help you. That's a different conversation than who's in control. That's a different conversation than are you the boss or I the boss. It's a shared conversation, and it says, I understand you want this, but this is more likely to hurt you than to help you. No one would want that, and that's where it helps. Reduction in pre-op screening, this is one of my favorites. Daniel Wolfson, I already mentioned him, the EVP of the foundation. He has taped to the wall in his office the EKG that he had before he had cataract surgery. You don't need an EKG before cataract surgery. There's recommendations not to do this stuff before cataract surgery. It's low-risk surgery. And at LAC USC, and this is an inner city hospital, they instituted guidelines to not do pre-op testing before cataract surgery. On the well, if you're looking at the left side of the slide, you see the clinical impact of drop in unnecessary X-rays, EKG testing, lab tests, and that's money in the bank. But the right side is what's cool. Anybody who works in a safety net institution knows that there are all kinds of delays for accessing care. Pre-op testing wound up being a delay. And what they were able to demonstrate was if you took out the pre-op testing and just did the surgery, you could do the surgery 6 months sooner, which for cataract surgery in older folks was 6 months of improved vision. So this is not just money. This is actually better clinical outcomes that patients experience. At Detroit Medical Center, another inner city underserved health system, they did a bunch of things on lab work and imaging, focusing on low back pain and vitamin D tests, unnecessary vitamin D tests. And again, some of this involved clinical decision support, putting stuff into electronic health record alerts. I'll talk about some other examples of that. But you can look on the right of the slide, 5 ways to be smart about back pain. Able to give a patient something when the patient's asking for the MRI, to be able to say, the MRI isn't actually going to make you feel better. It's not going to make you any more active. It's not going to help you achieve any of the goals you're trying to achieve. But here are some things that you could do that will actually help. So again, it's not, I'm going to slam the door on the MRI and tell you you can't have it. It's, we're going to focus on what it is you're trying to get and help you try to get that. So these are these are examples from the field, but part of what's happening is increased awareness. I was deeply encouraged, I'll admit it, by the number of hands that went up of people who are familiar with choosing wisely. But we've got some literature evidence that there is broad awareness, and to some extent you're pushing against an open door. As I say, doctors used to think we had no responsibility for resource management at all. We used to think that was only the accountant's problem. That really is changing, and people understand that that they need tools to succeed. The emergency medicine discussion is interesting, and the reason I'm using this example is the American College of Emergency Physicians was very ambivalent, that's putting it mildly, about joining the Choosing Wisely campaign. And in fact, when we started Choosing Wisely, in that initial slide I showed you with Daniel and the 9 societies, we had approached a bunch more societies than that. And they said, why would we come out with recommendations that will cut the income of our members? That's a terrible idea. Our members are going to hate us. We're going to get in trouble. We shouldn't do it. And it was only after the initial group got on board, and it was a man bites dog kind of story. It's, wait a minute, doctors are recommending less testing? And that was front page news in a variety of major media outlets and got a lot of press, and that encouraged people to get on board. But the emergency medicine physicians raised a different concern that we also often hear, and I'm sure if I didn't talk about it here, it would probably come up in the Q&A. How about malpractice, especially in New Jersey? How about malpractice? You don't do a test, aren't you going to get sued because you didn't do a test? And the emergency physicians were really worried about this, and they said, we're not going to make this recommendation on behalf of our college because we think it's going to expose members to liability. And what they wound up doing was having a pro-con debate at a open forum at their national meeting. And where they came, which is where responsible clinicians get when you think about this, is litigation is an inalienable right of citizens in this country. You can get sued for doing the right thing, you can get sued for doing the wrong thing, but you're on firmer ground if you did the right thing. If you do an unnecessary test and there's a complication from that, you have just as much liability, maybe more, than if you forewent an unnecessary test. And I think the realization of that caused the the American College of Emergency Medicine to get on board, and people did feel that that it helped them in their conversations with patients. There's a lot more coverage of this in the literature. The number of articles nearly doubled, and it's just an enormous number of discussions in the professional literature these days. And I've already mentioned it's very much a bottom-up approach, that it's designed to be flexible. When people call us and say, how should we implement choosing wisely in our system, there's a bunch of different ways you could do that. You can take some of the lists, but what we really encourage people to do is ask yourself where there might be overuse in your setting. Ask yourself what you think might be relevant to your setting, and then in that setting, pick the things that work for you, and Choosing Wisely is meant to be a toolkit that will work for you in your setting, rather than, oh, you got to do the whole program. You should pick and choose as appropriate and really try to customize the interventions in ways that make sense for you. And one of the ways that some of the people are using Choosing Wisely as the solution to a problem, you've got, it's coming into the medical education environment. And one of the things in the teaching value group that I love that they started doing in residence in rounds once a month when people were on service, they would actually review with the clinical team the hospital bill from a patient they'd taken care of earlier in the month. If anybody in clinical training look at a hospital bill for a patient that was actually they were taken care of, I mean, there's just a total lack of awareness on the part of people providing care. That kind of bringing it into the educational system shows that it's normalizing to think about resource consumption. And this is a Twitter convo with people talking about choosing wisely in high value care. These are medical students. We have what we call the STARS program, inviting medical students around the country, and it's medical students basically pushing faculty to say, well, why are we not doing choosing wisely? Why are we doing unnecessary services? Again, you talk bottom up. It doesn't get more bottom up than medical students in an academic health center telling the faculty what to do. But you do need system and performance improvement approaches. Again, as I already mentioned, Scott Weingarten was one of the early folks doing Choosing Wisely at Cedars-Sinai, and they had an Epic. They had Epic in their hospital, and they put in a bunch of Choosing Wisely recommendations into the electronic health record, and they believed that they generated about $6 million annual savings in the hospital from using these alerts and being able to track avoided care. And the implementation of the electronic health record is one of the major ways that people have instituted Choosing Wisely with decision alerts and stuff. And of course, the original way this happened was Scott did all the work to put it into Epic, and then it was like, well, now that you put it in Epic, does everybody have it? And Epic being Epic, it was no, it was their installation. But my understanding is that subsequent releases of Epic have been much more open to being able to put Choosing Wisely in, but I can't address that specifically for you. And then here's Christiana Care, and when I was talking about avoided lab tests in the hospital setting, this was looking at recommendations on telemetry and trying to hard code those into the way the order sets worked. And again, the engineering approach. Order sets are designed to kind of be efficient, but then they wind up hard coding inappropriate stuff. They were able to generate a 70% reduction in Christiana Care in Delaware with a daily savings of over $13,000. And this is one of my favorites. This one was a resident-driven program at a Johns Hopkins hospital where they said, the way we're doing troponins on patients in the hospital who are there to rule out myocardial infarction, when the first one's negative, we're not supposed to repeat them, but they were doing routinely sets of 3, 66% reduction in tests ordered, $1.25 million saved in year 1. And that's a resident-driven program. And the point I'm making here is not that you should run back to your hospital or health system and put in place hardcore troponin orders. You could if you want to, but it's more that you can start having conversations in your team, and what starts to happen when you do that is people see all kinds of opportunities and all kinds of ways to approach this, to integrate it into clinical workflow. A lot of what Choosing Wisely is about is really, I use the word getting people in the game. At the end of the day, what the biggest challenge is for frontline clinicians to see this as something that they can change, that they want to change, that they will change. If clinicians feel like this is something done to them and not with them, they're not likely to do it, and nobody wins. So just summarizing, what are some of the most effective interventions? Clinician feedback, peer comparisons. No clinician wants to be at the low end of the bell curve. It's one of the most powerful tools that you have, presenting people comparative data of how they're doing relative to other people. One of the Choosing Wisely implementations, regional implementations that I don't have a slide on, was ASCO, the Fred Hutchinson Cancer Center in the Pacific Northwest, took the ASCO clinical recommendations for cancer management, and across a bunch of different practices in the Fred Hutchinson Center, they audited adherence to these recommendations. And as always happens when you do this, there was a pretty dramatic spread. Different offices were doing different levels of adherence. And the people who saw how poorly they were doing said, this is really bad, and were motivated to change. So clinician feedback, peer comparisons matter. I've already spoken about clinical decision support, such as EHR integration. Clinical champions have been an interesting way. We've used that from the foundation, working with the original society partners, inviting societies that made recommendations to nominate for special recognition somebody in their society who got really excited about Choosing Wisely and was a kind of leader to bring everybody else along. And those people were called clinical champions and formally recognized. Again, it doesn't sound like much, it doesn't cost anything, but if in your institution you were to identify a clinical champion for Choosing Wisely and at a lunch or a staff meeting or something, hand that person a certificate and say, thanks for your leadership in this area, it's a way to get people to step up and give them recognition and reward for doing it. And I've already mentioned changes in order sets, guidelines, and workflows, that stuff is a lot of how we collectively do our work. So I mean, hey, it's a tech conference, so I do have to close with, when it stole my thunder a little bit, we do have a very friendly website, which we recently redesigned, and you can see it's got things like, where should I start? Am I choosing wisely tools for clinicians? How can I implement it in my practice or health system? This is really meant to be sort of hands-on. I know that the workflow in primary care expands infinitely, and nobody's looking for more work to do. These are ways to integrate it into workflow so that it doesn't have to be the frontline clinician doing stuff, and there's other people who can help, and it really can be a team sport. And this is, what you see in Am I Choosing Wisely and ways to go through. We worked with Drexel College of Medicine to create some online videos that model some of the Choosing Wisely conversations. So you can look at those. They're simulated encounters. These are useful educational tools. And there are a variety. You can choose among them. These are some of the videos: communication skills, lists of things to discuss, and so on. And by the way, all these slides are going to be available to all of you, so you'll be able to find this. Good, I didn't kill it that time. You'll be able to find this. And then the Choosing Wisely app at the tech conference. It is free. Download it. I've got it on my phone. You can get it on yours. And you can search it by society. You can search it by subject. And again, it's sort of a point of care aid that can help in conversations with patients. And the other thing we've done is learning networks and communities, and you all are welcome to join in on this, and Linda, on your behalf, can come up with a way for you to connect to this. But we really have two things. We have the Choosing Wisely Learning Network, which is focused on sort of frontline folks, and then there's a health system leader learning network. And as always, it's people sharing experience and getting better through learning how other people have solved problems, and our foundation is supporting those. So thanks for your interest in the topic. Thanks, Linda, for inviting me. As I say, great to be back here and see real world change on the ground. And I'm happy to answer any questions about choosing wisely, or if there are residual questions about comprehensive primary care. Linda said I could talk about that too, but whatever is of interest to you. Anyway, thank you all, and really appreciate your being here this morning. And we do have time for questions. Over there. Okay, great.
Hi, I'm Shahid with a company called Citus Health. I was curious, so what is, as far as the adoption is concerned, where is the struggle? Is it just people knowing about it, or once they learn about it, there's additional that they have to understand before applying it? Because it seems like a great program. It should be easily adoptable, but there's got to be some struggle.
Well, yeah, I mean, I think the struggle, that's a great question. The struggle is the struggle for mental and emotional bandwidth that we're all struggling with in healthcare, right? You know, everybody's got the inbox that's overflowing. Everybody's got the EHR to-do list that is overflowing, and it can feel like one more thing. You know, people at our foundation describe this initiative as like lightning in a bottle. As I say, we're a small foundation. This thing really took off. We'd love to say it was because we were geniuses. I don't think so. I mean, we got some things right, we got some things wrong. What really helped it take off was that it hit the world at the time people were talking about value-based contracts, accountable contracts. So I think the most important feedback I've gotten from health system leaders who are asking your question is they have put their clinicians in an environment where they want them to behave differently. And the clinicians need tools to succeed, and presenting Choosing Wisely as a tool that can help you succeed helps that move forward. And again, I think changing workflows, you know, somebody's got to do that. You have to have practice meetings, but we're living in a world where you've got practice transformation networks. You are one. People are thinking about that. People are understanding the opportunity to do that. So I think it's mostly that, a certain amount of skepticism, because there's been some skeptical, critical coverage, like, you know, the orthopedists took a pretty softball approach to their Choosing Wisely list, in the opinion of some. A lot of procedures in orthopedics that are done more than they ought to be done didn't make the list. And so people have made criticisms of Choosing Wisely, saying, you know, you should have curated that list, you should have pushed those guys, you should have said you really, and frankly, our view of that was what we lost in the rigor of the orthopedic list, we gained in the engagement of not demanding, and who were we to be peer reviewing what the American Academy of Orthopedics was going to say. My favorite Choosing Wisely impact story, and I know there's entrepreneurs here, a friend of mine that I worked with at the Innovation Center reported back after he left the Innovation Center, he was working with some advocacy firm, and he was at a venture capital meeting in New York that Morgan Chase was sponsoring, and somebody did a presentation at that meeting on Choosing Wisely. It's like, why are they presenting on Choosing Wisely at a Wall Street meeting? And apparently the guy's setup was, well, if you as healthcare entrepreneurs want to know where the puck is going, take a look at what the clinicians themselves are looking at. They're looking at this thing, Choosing Wisely. And one of the recommendations that he highlighted was a recommendation from the American Society of Radiation Oncology that said you shouldn't use you shouldn't use proton beam radiation for prostate cancer except in a clinical trial setting. Now, for those of you who are not clinically oriented, a course of proton beam therapy for prostate cancer costs about $250,000 and has no known benefit relative to other forms of treatment for prostate cancer, which can be less than $5,000. why would you spend $250,000 and not $5,000? And what happens is once you own your proton beam scanner, you got to keep it busy. It's magnificent treatment for unfortunate children with brain tumors in difficult to get at places because you can precisely target the therapy and you don't have collateral damage. But it's not good for prostate cancer, but there's a lot more prostate cancer than there are kids with. Well, what were academic health centers doing? They didn't want to buy their own PET scanners, proton beam machines. They were partnering with venture capitalists. And as I understand it, a bunch of those deals went south when people said, oh, wait, there's not going to be such a big market for proton beam therapy. So it's funny how this stuff works, but it can go in multiple directions. So that's more than you asked. Sorry, yeah.
The name is Noah Laloga. I'm a practicing primary care physician here in New Jersey. And I'm glad the Choosing Wisely has a component for patients or the general public. But unfortunately, a lot of people don't always get to use these apps. They're more inclined to listen to the news and to be aware of like high jury awards that go to malpractice victims. And how can you make this more widely available? There are comments on the TV telling people to get screened for hepatitis C. How can we introduce this dialogue widely on mass media so that if there's a jury award, they're going to be informed and that physicians are not penalized because they haven't done something? Because the fear of litigation is real. A lot of people may not admit, but the fear of litigation is real. How can we widen the scope? Because in societies in Europe, it's different. Their perception is different. How can we make our perception here in the United States to understand that overuse could be a problem?
Well, great question, and thanks for taking on the awesome responsibility of being a primary care doctor in New Jersey. You are doing more than you know every day, and part of your heroism is being willing to take that on to go out there with patients, knowing that you're in a pretty crazy environment. And again, I know New Jersey is a major center of malpractice litigation. There's not going to be any one solution to that. I think we all know that. Part of, you ask, how do we make this more widely known? Well, I live in Philadelphia and I'm in Newark, New Jersey at 9:30 in the morning to tell all of you about Choosing Wisely because it's branded in a way designed to generate trust. And one of the big struggles that we're in right now in the social media world, in the fake news world, is that people are getting more and more information from Facebook, more and more information from Twitter, and it's actually undermining trust in physicians. It's undermining trust in expertise. The whole idea of knowledge and expertise is somehow under threat. A lot of what the American Board of Internal Medicine is about is putting out a credential that a patient can trust that this is someone who actually has skills, as opposed to somebody who went on the internet and got the New Jersey Institute cardiology certificate. That it really is a distinguishing credential. All of us need to struggle for legitimacy and credibility. And a lot of the design of Choosing Wisely is designed to empower you so that when you're having this conversation with a patient, it's not you against them. It's still a shared decision, but you're saying, look, this is what the American College of Cardiology says. It's not just me, and the ABIM Foundation and Consumer Reports, that all these names together generate more trust in patients. Is it going to end lawsuits? No, it won't. But will it better position you to have the kind of interaction with a patient that's less likely to result in litigation? Absolutely it will. Other questions? Yeah? Oh wait, back there? Yeah.
Thank you, Dr. Barron. Sandy Salzer from New Jersey Academy of Family Physicians. So there are a lot of conversations and evidence that certain conversations with a patient go better if the physician has that recommendation. Are you finding that with Choosing Wisely? Because as we expand our practices to include more medical assistants and mid-level providers, should and has Choosing Wisely been introduced in nursing schools and medical assistant schools? And so the patient is getting the same message from the time that they enter the office saying, I need a CT scan. They're getting the same message from the medical assistant who's rooming them to the nurse, to the physician. Just wondered kind of how that's been taken in terms of the Choosing Wisely recommendations.
Great question, Sandy. The American Academy of Nursing was actually the first non-physician organization, along with the physical therapists, to be on the list of 80 medical organizations making recommendations. So we did engage nurses. I think the point you're making, most of the time medical assistants and nurses are operating under the supervision of a physician, and it's really a workflow redesign question. And are we finding that medical assistants can deploy Choosing Wisely tools? Absolutely. They're meant to be self-executed. If what you're handing somebody is information about why they don't need an MRI for back pain, like the example that I showed, certainly medical assistants can do that, nurses can do that. And it's more about the effectiveness and credibility of the communication. I think everybody in an office knows that that care is a team-based sport these days, that trust is not uniquely generated by physicians, and that the campaign is designed in a way that it is very much meant to be consumer friendly. And we're aware of lots of situations where non-physician clinicians are communicating Choosing Wisely recommendations. But thanks for asking. Yeah.
Lisa LaCaruba, I'm medical director at Horizon. I'm also a family physician. And you brought up social media. And I'm curious where you're thinking of taking this, because one of the things I struggle with, I see on social media lots of posts about the harm vaccines, for example, cause, which is totally different direction from what we're trying to do with Choosing Wisely. You also see all the tests that your physician should be doing, like the screening for ovarian cancer, that doesn't exist. So I look at what my family members are posting and my friends are posting on social media, and it's so inaccurate. And you brought up in this era of fake news and who can you trust and how Choosing Wisely is branded, and the app is great, but my family members are not going to go on the app, they're going to go on Facebook. So are there plans to, how do you bring this out, Choosing Wisely, to a more broad audience so that when people go to the physicians, they've already seen it? I think we're in a day where just listening to your physician may be enough for some people. For other people, they're really going to other places for their news. And I think the more you hear it, like Sandy mentioned, you need to hear it from your medical assistants, you need to hear it from your nurses, you need to hear it from your physician, you need to hear it from the news, like was mentioned earlier, and you need to hear it from social media. And how do we get this out more broadly to the patients?
It's a great question, and it's probably the question of our age. As you know, managing social media is not like, getting an op-ed placed in the New York Times. It's much more diffuse. It's not a top-down sort of strategy. And there's a whole other talk I give on trust and credibility in this age. And you're absolutely right. Increasingly, data are suggesting that people are getting more news from Facebook than any other place. And not only that, what they're getting is the echo chamber stuff, and it comes from a friend, so it's more trusted. There's a group, the Edelman group, that does trust surveys every year, and they ask the question, who would you be most likely to trust? And one is someone like you, and another is an expert, and they are neck and neck in terms of who you're most likely to trust. And I think this is a deep issue for healthcare. And again, I'll go back to the boards have taken a lot of heat lately for all kinds of things, but I think one of the things that as a profession we're responding with is we're saying, hey, there really are people who know what they're doing and continue to know what they're doing, and they've got a credential they can show you that says that. It's one element in the trust equation. We certainly do a lot of social media stuff around Choosing Wisely. The foundation tweets about it, we put it out on Facebook pages. various Choosing Wisely champions use their social media stuff to get it out there, but it's not reliably as interesting as, and the other thing we're discovering about this is that that fake news with alarming headlines spreads faster than real stuff, and it's an issue for the country politically. It's an issue for doctors, and I think we are, in fact, the next big thing at the foundation, Choosing Wisely, is now 6 years old. Our foundation is pivoting to trust, and that's exactly what we're thinking about. And we're hoping to take on that issue in a way that would have as much impact as we've been able to have with Choosing Wisely. But thank you for raising it. It's really critical.
Yeah, hi, Dr. Nazra. I'm a primary care physician in New Jersey and medical director of 2 facilities for the subacute rehab. And the program is wonderful. However, it is really addressing people who are fully aware of it and have a lot of incentive into it. But the reality is the true struggle is when it comes to the patients. The patient comes already to the office charged what they need to be done. Now, I spend so much time. As a matter of fact, I see maybe 2 patients an hour, and I run between exam rooms to avoid the looks from my staff because it's taken so much and it becomes unaffordable. And I sit down and I talk to them. But obviously, they basically had their tests looked already somewhere else, looked into the media, looked into the Facebook, social medias, and so forth. So the true struggle and hindrance to that is what the patient actually is fed with when they come to you. Back pain. Once they have back pain, if it does not resolve in 1 week, if they don't have the MRI, there is something missing by the doctor. You insist and you say it really is not appropriate. It probably may cause you harm. It may show something that is not causing you pain. You end up seeing a surgeon. You may have surgery and you still have the pain as well as the surgical pain. They change the primary. They go somewhere else until they get the MRI. So this is truly the struggle is with the patient, and the investment should always be where the services are to be delivered.
Yeah, absolutely. And again, thanks for your work taking this on directly and for being a frontline clinician. We have high standards for ourselves as doctors, and we think of the patient that you just described, and we think, what's the point? We really can't get this done. The guy that I told the story about the colonoscopy, I remember him for 2 things. I remember the colonoscopy story. I also remember the story of talking to him about quitting smoking, which we talked about over 2 or 3 years, and then he finally quit smoking and he gave me credit for it. Now, the number of people that you can think of that you got to quit smoking is probably 0, but it may be more than you think. And the way we should think about using a tool like Choosing Wisely is not that 100% of the people who come in with back pain are going to leave with no MRI. But if you could get 20 or 30% of them to leave with no MRI, if you could get into a conversation that says, look, I'm the way you just presented it is actually gives more space for the patient to understand how this test might hurt them. That's not commonly available to patients. And if a patient, and what Choosing Wisely does is it gives you, as I say, a branded, trusted source. It's, look, I'm your doctor here. I don't have a dog in this fight. I'm not making more or less money if you get the MRI done. But I can tell you that the American Academy of Family Medicine doesn't think this is the right time to do an MRI, and I agree with them. And the reason they think that is they think it's more likely to hurt you than to help you. And here's the ways it could hurt you. If you say to patients, antibiotics may hurt you, that's one thing. If you say, one of the major hospitalization reasons now is C. diff colitis, which is coming from unnecessary antibiotic use, that's a different message to a patient. Will we be successful all the time? No. But if we have a 30% effect size, a 40% effect size, even a 20% effect size, every one that's avoided is something that's avoided. So don't despair. You go to work every day, you're trying to do what you're trying to do. Sometimes you succeed, sometimes you don't. This makes it more likely that you'll succeed. Not going to guarantee success, but it gives you an extra pathway.